Hello everyone, and warm welcome to all attendees of this ultrasound webinar featuring the basics of breast ultrasonography and how to utilize real-time tissue elastography. My name is Takashiro Hirano. I'm manager at Ultrasound Marketing Department of the Diagnostic System Division at Fujifilm Healthcare Corporation in Japan. Before starting today's webinar, please watch the video.
From a pioneer in photographic film to a master of the digital age, we're always searching for new ways to imagine, create, and capture your world. But why stop there, when there's so much more we can do? In healthcare, we're revolutionizing diagnostics by applying our imaging expertise and AI technology, which aim to enable earlier detection of disease. But why stop there, when we can apply our expertise in cell biology to help make vital vaccines and treatments available to all? And we can focus our research and development on medicines to tackle unmet medical needs, including cancers and infectious diseases. But why stop there, when we can also consider the health of the planet? Our innovations in data storage are reducing CO2 emissions. We'll never stop innovating for a healthier, more sustainable world. Fujifilm, value from innovation.
Again, welcome to the Fujifilm Healthcare webinar. Today's topic is the basics of the breast ultrasonography and how to utilize real-time tissue elastography. Breast ultrasound is now widely used based on the BILAS US of American College of Radiology. It provides high 2D image quality, but sometimes physicians may face difficult cases to diagnose from B-mode findings alone. Dr. Itoh has a huge experience of the breast ultrasound, and she's doing the comprehensive diagnosis based on B-mode, color Doppler, and elastography. She gives you how to interpret acquired information properly and share her experience through clinical cases. Dr. Itoh works in the Department of Breast and Thyroid Surgery in the Hitachi General Hospital, and we were working together to develop our real-time tissue elastography since the beginning. She explains examination procedure of each method and how to apply the acquired information to make a diagnosis. This is a pre-recorded session, and you can ask any questions by email you will receive after the webinar. The respective answers will be made available by email and on this webinar microsite by approximately October 8th. Therefore, please do visit this site in approximately 1 week to check the answers. Before starting the Dr. Itoh lecture, please allow me to provide you some insight regarding our name change, Fujifilm Healthcare. In March 31st, 2021, Hitachi's diagnostic imaging business was successfully transferred to the Fujifilm Corporation, and consequently, Fujifilm Healthcare Corporation started its operations. The new company will provide our customers with one-stop total solution by complementing and strengthening the imaging diagnostic business that grew from the medical field and wide range of the medical business that Fujifilm has. All our customers and partners can continue to count on our people, our service, our promise, and new synergies. Fujifilm Group offers comprehensive solutions through the development of the extensive lineup of the medical technologies, including X-ray, mammography, ultrasound systems, and endoscopic instruments. These products offer the synergetic effect with the diagnostic imaging devices. Although the world has changed dramatically, we will not only respond to these changes, but change ourselves. Fujifilm Healthcare Corporation will provide new value for healthcare. So let's start the lecture from Dr. Itoh.
I'm Itoh. I'm a breast surgeon of the Hitachi General Hospital in Japan. Today, I'll talk about breast sonography combined with color Doppler and elastography. Ultrasound is a modality indispensable for the diagnosis of breast disease. The diagnostic performance of breast ultrasonography has been improved recently by not only B-mode image quality improvement, but also the combined use of color Doppler and elastography. On the other hand, it is getting a new problem how to make use of examination procedure of each method and acquired information for better diagnosis. Today, I'd like to explain basics of B-mode color Doppler elastography and the actuality of breast ultrasonography. Today, first, I'll explain B-mode imaging effective for diagnosis. Next, I'll explain the examination procedure and evaluation method of color Doppler and real-time tissue elastography. In the end, I'll show the actuality of breast sonography using B-mode flow imaging and elastography. First off, I'll talk about how to take B-mode images effective for diagnosis. As you know, breast ultrasonography is performed based on BIRAS US of American College of Radiology. Most breast imaging lexicon words of this BIRAS consist of morphological features and qualitative features acquired from B-mode images. Morphological features are the information like shape and margin, which express the shape of the target. Qualitative features are the information like echo pattern and posterior features, which express the composition of the target using the characteristic of ultrasound. In addition to such information, we use associated features like calcification and architectural distortion to assess the benign or malignancy and the type of tissue. This is BIRAS US quick reference. Most items of this table are the information acquired from B-mode. These cases can be diagnosed easily from morphological features and qualitative features acquired in B-mode. As with all imaging modalities, the value of US for detection and diagnosis largely depends on the quality of the images. Especially in handheld breast US, the images to be the evidence of diagnosis differ not only by the performance of the US system and the transducer, but also by the examination skill of an examiner and the timing to store as still images. Let me show an example case. Please see a movie. Examiner can take both still image A and B from the movie of the last slide. From image A, you can judge this case is an anechoic tumor with clear boundary or cyst. But in image B, it looks like a tumor with unclear boundary and irregular shape, so the malignancy can't be denied. Your judgment differs by which image of A or B to store. As US described, US image quality can lead to serious misinterpretations, such as mistaking a cyst for a cancer. You need following 4 things to take high-quality B-mode images. Above all, the performance of US system and transducers. How to hold a transducer and its angle. Next is the degree of the compression to a breast by a transducer. In the end, the timing to store as a still image. Usually, we set the focus on the position of mammary gland during screening, but Variet supports a function named e-focusing, which delivers clear images from near to far field and keep high frame rate. It's a very useful function to observe the whole breast. These are breast tumor images taken with Areta. The irregular shaped outline with echogenic halo and the internal structure with cystic change are clearly delineated. When you hold the transducer, hold the lower part as much as possible and keep it perpendicularly to the skin of patient breast. The weight of cable can be relieved by hanging on your shoulder, and it gets easier to move the transducer. If you hold the upper part of transducer and tilt to scan, it leads to a low-quality image. Naturally, breasts are curved, so tilt the transducer around the curve and keep it perpendicularly to the skin of breast during screening. Take care to keep the skin and mammary gland and the pectoral muscle parallel in the image. Let me show an example case. Please see a movie. This is a case of intraductal papilloma. If the skin and the pectoral muscle are imaged in parallel and uniform compression is applied to a mammary gland like image A, you can judge the lesion as a tumor with clear and smooth boundary. If the skin and the pectoral muscle are not imaged in parallel in the transducer compression is not uniform like image B, you can't judge the margin and it could lead to a misdiagnosis. The compression to the breast by a transducer also affects the image quality. In B-mode images, compress the breast a little by a transducer to thin the subcutaneous fat. It enables to image the mammary gland in the shallow position and delineate its shape and internal structure clearly. Let me show an example case. Please see a movie. In image A, you can judge the region as a circumscribed lobulated mass, and the internal structure can be confirmed as well, so this region can be diagnosed as fibroadenoma. But in image B, the boundary is unclear in part, and the malignancy can't be denied. The difference between image A and B is the compression by a transducer. In image A, a subcutaneous fat is thinned and the position of lesion is shallow so that the image gets clear. Next, I'll explain the effectiveness of flow imaging and elastography. If imaged properly, Many cases can be diagnosed from morphological and qualitative features in B mode. But sometimes you face a case like this, which is difficult to be diagnosed from B mode findings alone. For such a case, vascularity information by flow imaging like Color Doppler and elasticity information by elastography can be helpful for diagnosis. In virus, vascularity and elasticity assessment are described as associated features. When you are lost for diagnosis in B mode, vascularity and elasticity assessment information is effective as reference findings. But to make it really effective, these two matters are important. First, take image with appropriate setting and examination procedure. Second, interpret the acquired vascularity and elasticity assessment information properly. If you mistake in these matters, it could lead to misdiagnosis. Next, I'll explain the examination procedure and the evaluation method of Color Doppler. Flow imaging has Color Doppler and Power Doppler. We are using Color Doppler because not only blood flow velocity, but also the directional information can be acquired. As to the color of Color Doppler, red means flow toward the transducer, and blue means flow apart from transducer. Generally, the blood flow velocity in a breast region is low, so we set the Color Doppler velocity range as 5 cm per second or less. The default setting in our hospital is approx 3 cm per second. At that time, set the size of ROI with 5 to 10 mm margin from the boundary of the target region. When performing Color Doppler, it is important not to compress the breast strongly by a transducer, different from B-mode examinations. If a breast is compressed strongly by a transducer, the blood flow is interrupted and the vascularity could be imaged poorly. So the transducer like photo A is appropriate in Color Doppler examinations. But in case of a region located in 2 cm or deeper from the body surface, little compression could improve blood flow delineation. Vascularity is classified into 3 patterns in virus. Absent is no vascularity in a region like photo A. In case of internal vascularity, blood vessels are present within the mass, like photo B. If classified as vessels in limb, blood vessels may be marginal forming part or all over limb around mass like photo C. On the other hand, vascularity is classified into 4 stages in the rule of Japan Association of Breast and Thyroid Sonology. Additionally, the blood flow pattern and its distribution are classified into 2 patterns of benign and malignant. Avascular means no blood flow in a tumor same as absent of virus. Hypovascular means only spotty signal or one blood flow found inside the tumor. Moderate vascular means multiple, approximately 2 to 5 blood flows inside the tumor. Hypervascular also means multiple blood flows inside the tumor, but this evaluation is different depending on size of mass. Additionally, if multiple blood flows are found inside the tumor, it is classified into benign and malignant pattern by the shape and the distribution of the vessel. In benign pattern, the blood flow velocity and direction are uniform. On the other hand, in malignant pattern, vessels is trichoelastic and mosaic pattern, and the vascularity is increasing in surround tissue. In these cases, both A and B are judged as hypervascular because multiple blood flows are found inside the tumor. But if a blood flow is smooth and running in uniform velocity like A, or running along the boundary and the septum, it is regarded as benign pattern and characteristic of fibroadenoma. On the other hand, if a blood flow is trichoectatic like B and the velocity is not uniform, look like a mosaic pattern, or the vascularity is increasing in the surrounding tissue, it is suspected as breast cancer. In case of cyst or complex cyst, if no vascularity is found inside, it can be a decisive factor of diagnosis. As to fibroadenoma, calcified and absolute ones show a vascular pattern, but the ones in younger age and the new or increasing ones show high vascularity. Their vascularity is variable, but it is characteristic to show benign pattern blood flow. Most breast cancers have high vascularity and show malignant pattern. But among invasive ductal carcinoma and invasive lobular carcinoma, the ones have more connective tissue than cellular component. In other words, the region with posterior echo attenuation in B modes show hypovascular. Pheroides tumor and malignant lymphoma also show high vascularity. A is the blood flow of fibroadenoma. It is hypervascular but monotone and smooth pattern. B is hypervascular intraductal papilloma. C is invasive ductal carcinoma with poor vascularity. Blood flow sensitivity difference by US system needs to be cared. Image A and B are of the same case DCIS. A was taken by an old system and blood flows are scarcely found inside the region. But B, which was taken by a new system, can be judged by hypervascular. It is important to grasp the blood flow sensitivity of the system you are using routinely. Next, I'll explain about real-time tissue elastography. Professor Kraskop and other researchers found that breast cancers are harder than benign lesions and normal mammary glands in 1998. This is the research to be the basis of elastography. Elastography is a modality to evaluate the hardness of the tissue by using ultrasound. It has two methods. Strain elastography to visualize strain distribution generated by manual compression, and shear wave elastography to evaluate the hardness from the propagation speed of shear wave in the tissue. Fujifilm Healthcare has released the first strain elastography system suitable for clinical use in 2003. This is called Real-time Tissue Elastography, RTE in short. Strain elastography like RTE is used mainly in breast application now. The principle of strain elastography is assume tissue as spring and visualize the comparative strain distribution generated by light compression applied from above. RTE displays average strain is green, harder component is blue, and softer component in red. Take care that the color display could be opposite by manufacturers. When performing RTE, image the target region in the center of the screen, switch to RTE mode, and set the ROI. Put the transducer perpendicularly to the skin of the patient. Move the transducer straightly up and down by 1 mm. At that time, take care not to compress the breast too much and not to slide the plane to image. RTE image a comparative distribution of strain, so it is needed to cover normal mammary gland enough in the ROI, so that an appropriate image can be taken. Set ROI width to the full width of the screen, and ROI depth from just under skin to the pectoral muscle. Biomedical tissue has a property named nonlinearity, which changes the stiffness by the amount of applied compression. So if strong compression is applied by a transducer, an originally hard region could be imaged as soft, which could be lead to misdiagnosis. This is the same in the use of shear wave elastography to measure tissue stiffness. Whichever method used, it is strictly prohibited to compress the breast too strongly in elastography examinations. To take elastography images, hold the lower part of transducer and move approximately 1 mm up and down by fingers. It is important to keep the plane to image. Don't move transducer widely by the wrist. If it is difficult to move a transducer up and down, clear elastography images can be taken just floating the transducer straightly. Two methods are available for clinical evaluation of RTE. Tsukuba elasticity score to evaluate by image patterns, and strain ratio to quantify the elasticity ratio between lesion and fat. There is no difference of diagnostic performance between them because the same image is used. When we are lost for judgment or need to be objective, we use strain ratio. Virals US has 3 steps of elasticity assessments: soft, intermediate, and hard. I'll show the definition, the shame, and clinical cases of Tsukuba elasticity score. Score 1 and 2 correspond to soft or virus, score 3 to intermediate, and score 4 and 5 to hard. Score 1 indicates the even strain in the entire hypoechoic region. In other words, the entire tumor is colored by the same green as the surrounding mammary gland. Score 2 indicates the strain in the most of hypoechoic tumor. The most part is green, and the blue is mixed in some parts. Score 3 indicates the strain in the periphery of the hypoechoic tumor and no strain in the center. The center is displayed in blue and the periphery in green. Score 4 indicates no strain in the entire hypoechoic tumor, so displayed in blue. Score 5 indicates no strain in the entire hypoechoic tumor and its surrounding area, so displayed in blue. Artifacts may be found in large-sized tumors. The red or green dot or island-shaped area within the blue area are probably artifacts, but large tumors can be diagnosed by B-mode alone. It is sometimes difficult to make judgment for deep region because compression may be not reached there. In such case, I regard RT as the reference and emphasize other findings. We need to take care of score 2 and 4 differentiation. If the most part is green and blue is mixed some parts, it is score 2. Oppositely, if the most part is blue and green is mixed some parts, it is score 4. If a case like B is judged as score 2, it leads to a false negative. It is better to use FLR if lost for a judgment of such a case. The evaluation method to pick up the ratio of strain in two parts and quantify them is called strain ratio. In breast application, the strain ratio between fat and lesion is used. It is called fat lesion ratio, FLR in short. It quantifies how many times as hard as the lesion is compared to the fat. Please take care that the benign and malignant cutoff value differ by manufacturer and benignity and malignancy is not determined only by tissue hardness. This is an actual image of FLR. This case indicates that the lesion is 10 times as hard as the subcutaneous fat. It takes some time and step to draw circle in on the lesion and the fat. So Ariet supports a function named assist strain ratio. It is a function to detect the boundary between the tumor and the fat, set circle automatically and calculate FLR. In the use of this function, just move a cursor to the center of tumor and press Enter key of assist strain ratio. Then the circle for the tumor and fat are drawn and FLR is calculated. The time and steps for FLR calculation is reduced. But this lesion is benign even though its FLR is 5.9. As mentioned previously, benign and malignant is not determined only by tissue hardness. Therefore, it is needed to comprehensively judge B-mode, color Doppler, and elastography. If a category judgment can be made easily by B-mode, vascularity and elasticity are just reference information. But in some cases, you can get more conviction by adding such reference information. Color Doppler and elastography prove their merits for a difficult case to judge by B-mode alone. If you can assess a case as category 2, 3 or category 4, 5 by adding vascularity and elasticity information, the management after that can be fixed. Let me show you some cases. This is an oval tumor with clear and smooth boundary. It can be diagnosed as category 2 fibroadenoma. Blood flow is monotone and smooth and elasticity score is 1. So you can judge with more confidence by adding blood flow and elasticity information. This is a speculated and irregular shaped tumor. It can be judged as category 5 by B-mode alone. You can judge with more confidence by adding vascularity and elasticity information. This is a round-shaped tumor with clear boundary and its internal echo pattern is heterogeneous. It can be judged as category 4A just by B-mode. But it shows hypovascular and elasticity score is 2, so it can be judged benign. This case was fibroadenoma. This is an oval-shaped tumor. It can be judged as category 4A or 4B by B-mode. It shows hypovascular and elasticity score 1. This was also a case of fibroadenoma. If imaged with proper procedure, malignant possibility of elasticity score 1 tumor is 1% or so. As to this case, just B-mode cannot be a conclusive evidence and judged as category 4B. Malignant possibility range is as wide as 10 to 50%. The malignant possibility included by added vascularity and elasticity information, and it's judged as category 4C or 5. This was a case of invasive ductal carcinoma. In this case, the existence of lesion itself is certain in B mode alone, but it was judged as category 5 by adding vascularity and elasticity information. It was invasive lobular carcinoma. We refer to vascularity and elasticity information when lost for judgment in B mode. But how to judge when they are disassociated? The result of the case consideration in our hospital is like this. Soft and low vascularity cases had 1% or less malignant possibility. Soft and high vascularity cases had approximately 20% malignant possibility. Hard and low vascularity cases are approximately 40% malignant possibility. Hard and high vascularity cases had approximately 80% malignant possibility. A part of fibroadenoma cases has high vascularity like this case, but I think score 1 tumor can be judged as benign. Soft and high vascularity cases has approximately 20% malignant possibility. This case had elasticity score 2, but the possibility of non-invasive carcinoma cannot be benign, judged as category 4B, and needle biopsy was conducted. It was intraductal papilloma. The area like this, which shows partial hypoechoic area compared to surrounding mammary glands and difficult to be recognized as a mass, is expressed as non-mass forming in Japan. It needs DCIS and mast-patchy differentiation. Non-invasive carcinomas are known to be softer than invasive carcinomas, and some DCIS cases show score 1 like this case. High vascularity in hypoechoic area compared to surrounding mammary glands is cue to suspect to DCIS. As two reasons to suspect DCIS, emphasize vascularity rather than elasticity. Hard and low vascularity cases have approximately 40% malignant possibility. Complex cysts often show elasticity score 4, and it is characteristic to be a round, circumscribed mass and not to have vascularity inside. This case can be judged as category 2. This case was small-sized mass in B mode alone, and I was not confident to judge as category 3. But I judged as category 4B because it was hard. It was proved to be invasive ductal carcinoma after a needle biopsy. In case of a hard and low vascularity tumor, conduct a needle biopsy except a clear complex cyst. Hard and high vascularity cases have approximately 80% malignant possibility, but there is intraductal papilloma as representative case of high vascularity and hard benign tumor. It is to be category 4B to 4C, adding vascularity and elasticity information, so fix the diagnosis by a needle biopsy. The benign lesion, which is similar to invasive ductal carcinoma in morphology, vascularity, and stiffness, is sclerosing adenosis. It is to be category 4B to 4C, adding vascularity and elasticity information, so fix the diagnosis by a needle biopsy. This slide is about the comprehensive judgment by B-mode, flow imaging, and elastography. First, judge by B-mode. If you can judge benign or malignancy clearly from B-mode, in other words, judge as category 4 or 5, use vascularity and elasticity as just reference information and follow B-mode diagnosis. As to difficult cases to judge by B-mode alone, first, flow imaging is effective for the differentiation of cyst and complex cyst in clear boundary tumor. If you find high vascularity inside, judge as category 4 and consider a biopsy. Elastography is effective for the differentiation of invasive carcinoma and benign tumor, like fibroadenoma. If imaged soft in elastography, judge it as almost benign. In case of a hard tumor, judge as pro-malignant and consider biopsy, except a complex cyst from morphology feature and vascularity. In differentiation of DCIS, if it has high vascularity, conduct a needle biopsy. Intraductal papilloma and sclerosing adenosis are difficult to judge even after adding vascularity and elasticity information. The diagnostic performance of breast ultrasonography can be improved definitively by adding color Doppler and elastography as reference findings to B-mode. It is needed to get used to examination procedure and judgment methods, but the diagnostic performance is improved by performing as many examinations as possible by yourselves and feeding back its diagnostic results. I hope today's webinar can be a help to your routine examinations. Thank you for listening. I wish you a good health and happiness.
Thank you very much, Dr. Itoh. She presented clinical experience, how she makes the judgment with the ultrasound diagnostic information, such as B-mode, color, and elastography. Regarding your questions, please send your questions to the email address you will receive after this webinar, and respective answer will be made available by email and on this webinar microsite, approximately October 8. Therefore, please visit this site in approximately 1 week to check the answers. So today's webinar is over. Thank you very much for joining us and looking forward to see you the next webinar.